Thank you, organizers, Chairman sir. So the session is, oh my God. So when I see a patient who comes to me that he has been manipulated and it's failed, the first thing I say is, oh my God, this surgeon did a manipulation. And the reason I say that is, manipulation for a true frozen shoulder is fundamentally unacceptable to me. Let me tell you why I don't agree with it. First of all, MUA is a blind procedure. It's an uncontrolled procedure. You want to tear the capsule, but you don't know you may end up tearing the rotator cuff. You may end up causing a fracture of the neck of the humerus. It is unscientific. And let me take you through some of the slides of my experience of treating frozen shoulder for the last 24 odd years. But many from the audience might get up and say, like Dr. Vora is sitting here, that he might get up and say, what are you talking about? I have manipulated shoulders many times in my lifetime and they have been successful. They have been successful. This is what some of you might say. And let me crystallize the whole thing, that why this experience of having successfully manipulated the shoulder. It's because of inaccurate diagnosis. Those who have manipulated with success have probably not understood the pathology that they are dealing with. What do I mean? I take you back to Eugene Codman many years ago, and just read the last point, that it's difficult to understand from the point of view of pathology. We have not understood the pathology. All these pathologies have been analyzed and have been rejected. The closest to what is accepted today is Nevisier's concept that the pathology is in the capsule. Even that theory is more than 30 years old. First of all, majority of painful stiff shoulders are not real frozen shoulders, only 10%. So what are these 90%? They are secondary stiffness, secondary to a whole list of primary pathologies. Most often they are degenerative conditions like rotator cuff problem, AC joint, osteoarthritis, etc., etc. And when these patients present to you with a stiff shoulder, it is because of this kind of circle that they go through. Initially, they do some self-treatment, then they go to the family physician. 6 months have already passed. They develop a little bit of capsulitis. The original problem could be a rotator cuff tendinitis or a partial tear or a calcifying tendinitis, as we saw a case earlier. And when you manipulate this secondary capsulitis, you will have a successful MUA. So I think those of you who have had successful MUAs, it's because you have manipulated not a true frozen shoulder, but a secondary capsulitis. And these secondary capsulitis may have done well even without an MUA. So the true frozen shoulder, where do we stand now in 2017? This is the ISOCOS accepted universally consensus on how to define a frozen shoulder. Primary, as has been said earlier, is the one where the plain X-rays are normal. There is no identifiable pathology. And secondary is when you have an identifiable pathology, either clinically or on imaging. So let me share with you a small study I did many years ago. The incidence is about 10% of real frozen shoulder. The true definition is that there is a painful restriction, especially of external rotation and forward elevation with a normal appearing X-ray. So I had this series of about 30 odd cases, typical demographics. I won't spend much time on this. And what did I find? That the external rotation was the most painful and restricted, active as well as passive. Half of them were treated conservatively, half underwent arthroscopic surgery. This was way back more than 20 years ago, and the pain relief was dramatic. Now what I want you to see is that on arthroscopy what you see is a villus synovitis. And this villus synovitis is essentially in the rotator interval area. And the whole capsule is thickened and hard to penetrate when you pass your blunt trocar along with your arthroscope sheet. So those are the villus synovitis that you see next to the biceps tendon in the rotator interval area. But there are no adhesions there. There are no adhesions between the humeral head and the capsule. So Nevisier, R.J. Nevisier, 1945, that he reported is partly right. The pathology is in the capsule. The pathology is of a capsular fibroplasia, but there are no adhesions. So adhesive capsulitis is perhaps not a correct term. This data has been reconfirmed by many other researchers, Peter Willey, Ugelwit, Tim Bunker, 1994. All of these have shown that the pathology is in the capsule. And what is the pathology? There is random, uncontrolled proliferation of fibroblasts. I repeat, random, uncontrolled proliferation of fibroblasts. There are hardly any inflammatory cells, so it's not an itis. And I conned a pathologist at Jaslock Hospital. I showed this slide, and without telling the clinical history, and the pathologist said this looks like a fibrosarcoma. So this is just to give you an idea that the real problem is a capsular fibroplasia. And the structure which is most resistant to treatment, now I'll tell you about the MUA and why it leads to a fracture, is the coracohumeral ligament. Now let me show you what the coracohumeral ligament is. It's a double fold of the capsule. So it's like the parietal and the visceral peritoneum. This double fold of the capsule, it's not a true ligament, it's a capsule. When there is random proliferation of fibroblasts, these double fold of capsule get stuck to each other because of fibroplasia, and it becomes an inelastic, very solid, strong band. And now if you try to break this thick, solid band by manipulating, you could fracture the neck of humerus. So that's how you end up with either a rotator cuff tear or a fracture. This is a report by Richard Hawkins, 1993. Manipulation under anesthesia. The patient became as bad as he was before manipulation, and he summarized that manipulation has no effect on the course of the disease. So I don't agree with manipulation. Why? Because it is uncontrolled. You can do further damage, and I believe that we should not make the punishment worse than the crime. Resection of this resistant coracohumeral ligament may be an effective technique in those patients who are refractory to conservative treatment. You'll be surprised that in last 15 odd years, my incidence of doing arthroscopic release has dropped significantly, and I rarely do an arthroscopic release as well. Forget manipulation and anesthesia. What works is 1 or 2 shots of intra-articular steroid injection, and you'll be again surprised to know that I have not done an arthroscopic release for a true frozen shoulder for the last several years. So let me give you some insight as to what the world thinks, why this proliferation of fibroblasts takes place. These are the various etiologies which have been studied and disproved. There are certain comorbidities which are associated, especially diabetes. The incidence of frozen shoulder in diabetics is 4 times more than non-diabetics. There is a chemical which has been identified to be of increased incidence in the joint fluid in frozen shoulder. Why the fibroplasia takes place, I don't know. Why does this happen in certain diabetics and in certain non-diabetics, we don't know. But what we do know is, number one, frozen shoulder or true frozen shoulder is an uncommon condition. It is not an itis, it is a proliferation of fibroblasts, it's capsular fibroplasia. The structure which is most resistant to treatment is the coracohumeral ligament because of the anatomical disposition of that structure. Intra-articular steroid works. And in refractory cases, which is now a shrinking number, I may be wanting to do an arthroscopic release of the coracohumeral ligament. Post-MUA stiffness, so if a patient comes to me, what will I do? I will again inject into the glenohumeral joint, followed by mobilization, and usually it works. But this does not apply to secondary stiffness, which is post-operative stiffness. What I said is about primary or true frozen shoulder. And lastly, any research which reduces the need for surgical intervention is worth noticing. Thank you very much. Thank you, Ira.